Will there be any study guide? I think the exam next Wednesday.
No study guide, no. Nope. Yeah. Yeah, no, I don't ever give a study guide. It's based on the lecture. Yeah, so all the videos are posted, so you can study the videos. You can rewatch all the lectures. And then the PowerPoint slides, all of that will be, man, this semester goes fast, doesn't it? It's like quick. Yeah. So yeah, everything up through that we covered today. So we should get through the gram-positive coccus-shaped bacteria today. So gram-positive bacillus won't be on there because we haven't talked about it yet, but everything we covered today will be on.
It will be free response? Or
Mostly, yeah, mostly free response. Yeah, yeah. Okay, so today we'll cover gram-positive coccus-shaped bacteria. So whatever we cover today, anything we don't get to, not on the exam. We're definitely not going to get to the gram-positive bacillus, so those for sure won't be on the exam. Okay, so Staphylococcus, you've worked with these in microbiology lab before. So they are gram-positive circle, right, coccus-shaped bacteria. Gram-positive, what does that mean? What is gram-positive? Thank you. Thick layer of peptidoglycan as the cell wall, one single membrane. Okay. And so because this is stuff you should already know from bacteriology, even if we didn't go over it specifically in this class, like it is fair game for the exam. You do need to know the difference between gram-positive and gram-negative. But I also uploaded some videos that I recorded for my online class that I taught at Fresno State that cover the exact same stuff. So if you need a refresher on bacteriology, there are a couple of short videos that I already linked on Canvas, so you can watch those as well. So gram-positive, thick layer of peptidoglycan makes up the cell wall. They're also catalase positive. What does that mean? What's catalase do?
I know it like changes hydrogen peroxide to like makes it non-toxic.
Yes, yes, yeah. So catalase is an enzyme that we have and some bacteria have that turns hydrogen peroxide into water and oxygen gas. So when you do that test in the lab, hopefully you remember this, you have the slides, and if it's, you add a couple drops of hydrogen peroxide, and if it has catalase, you get the bubbles that form. So the purpose of having catalase for a pathogenic organism, it allows them to deal with various reactive oxygen species or toxic oxygen species like hydrogen peroxide. And that can be really important for human pathogens because one of the mechanisms that our immune system uses to help destroy invading microbes is by dumping things like hydrogen peroxide on them. So granulocytes can dump hydrogen peroxide, phagocytic cells within the phagosome can have hydrogen peroxide, and other reactive oxygen species. So if a microorganism is able to break it down, that is very helpful for them. In terms of clinical diagnostics, this is really important because hopefully you remember when you look at staph or strep under the microscope, you can't tell them apart. We'll talk about strep in a little bit. They're both gram-positive coccus-shaped bacteria. You can't really tell them apart. You can kind of say, well, staph is clumpy and this one is chainy, so maybe it's staph versus strep, but I wouldn't necessarily, start treating somebody's infection based on clumpy or not clumpy under the microscope. But I would based on a catalase test. Staph is catalase positive, strep is catalase negative. So if you have a patient with a gram-positive coccus-shaped infection, you think it's either staph or strep, dump some hydrogen peroxide on it and see if it bubbles. Okay. They do grow in clusters resembling grapes. You might remember this from doing a gram stain in bacteriology lab. Many are commensal, so we're covered in staph. Let's be real. If I gave you a mannitol salt agar plate and had you touch it, lots of stuff would grow. Or if I had you swab your nose, which we'll do later in the lab, lots of stuff would grow. But The challenge is that a lot of these can cause opportunistic infections. When your first line of defense fails, you have a breach in the skin, or maybe you're slightly immune compromised, these things can get in and cause very dangerous infections. Now, let's say that you have determined you have a Staphylococcus infection, but you're not sure which species of Staphylococcus you're dealing with. Another test you can do, another biochemical test you can do, is the coagulase test. Now, most of you did not do the coagulase test in the lab because you didn't have to differentiate between like Staph aureus and Staph epidermidis. Or, so those of you who had Staph aureus in your unknowns, you probably researched that other Staph species will also ferment mannitol and turn yellow. So you had to differentiate between Staph aureus and those. And the way you do that is that Staph aureus is the only one that is coagulase positive. And so coagulase, it coagulates, right? It causes clot formation. And so you can do that in a test tube where Staph epidermidis, for example, the solution will always be liquid. Staph aureus will cause it to coagulate, to solidify. So you can easily differentiate them in the lab that way. Okay. So the virulence factors of especially Staph aureus, so the proteins, toxins, behaviors it uses to cause disease, that's what we mean when we say virulence factors. Those are under the control of an operon. Do y'all remember what an operon is? You probably covered it in genetics. If you took it with me, you definitely did. Bacteriology, what's an operon? Yeah. Yeah, so what bacteria and archaea can do, so prokaryotic systems can do, is they can put related genes together on the chromosome, and they'll use a switch to turn them on and off, and they can turn on the expression of all of them at one time or turn them off all at one time. So a lot of the genes that Staphylococcus species can use to cause virulence are under the control of a particular operon. And that can be important, again, for thinking about how this bacterium is going to cause infection in the patients because of what genes are expressed at certain times. So Staph species at low cell density tend to not try to cause disease. They don't want you to know they're there. They want to be able to be in the body, to grow, right? They want to replicate and get to good numbers before they tell you they're around. They want to amass an army before they fight. So a low cell density will promote colonization. And bacteria talk to one another through a chemical signaling called quorum sensing. So every staph cell will secrete a molecule that can be read by other staph cells. And they can tell, hey, there's not very many of these molecules, there's not very many of us. We turn on the genes for colonization. But once the cells can recognize the signal, hey, there's a lot of us, now we're ready. Then the bacteria can turn on the genes necessary for invasion and toxin production. Right, so the analogy I like to use is like if you're thinking about invading Canada, I don't know why you'd want to, it's cold. But if you wanted to invade Canada and you were like the single person up there at the border, like, let's go, the Canadians are not, they're not gonna be worried about you. But if all 300 something million Americans got together and very quietly talked about this idea of, hey, let's go invade Canada. Eventually, when you had enough people buy in, not everybody's going to want to do it, but let's say most of the people want to do it, as long as you have more Americans than Canadians, you can do your sneak attack and it's harder to fight off. And that's basically what they're doing. We need to have enough cells so that it's really hard for the body to fight us off. So they wait. And a lot of staph species produce relatively common virulence factors. So they'll produce things like a capsule. Do you remember what the capsule does? or a slime layer. They kind of do similar things. So they're extracellular, right? They're on the outside of the cell. They are polysaccharide usually. Capsules are more tightly packed. Slime layers are more loosely packed. But one of the big things they do is prevent immune cell recognition. They hide their antigens underneath this sticky, gooey layer. The sticky, gooey layer also helps them to adhere to your cells. They have protein A. Protein A can bind to that constant region of antibodies and prevent antibodies from being recognized by macrophages. Because remember, the idea is macrophages, when they're going to recognize something that has antibodies bound to it, they recognize the Fc region. They recognize the feet of the antibody. Staph makes a protein that hides the feet, so they can prevent recognition by the immune system. Now, more uniquely, some staph species, mostly Staph aureus, produce toxins. Lots of toxins. So one of the challenges when you have a patient with a staph infection, you could have a patient come in that has vomiting and diarrhea. You can have a patient come in that's experiencing septic shock. You can have a patient come in with boils. All of those patients can have Staph aureus. Staph aureus can do all of those things because of different toxins. So it has cytotoxins that can destroy red blood cells and white blood cells. It has exfoliative toxins. So those of you who might find yourself working, especially in pediatrics, staph infections in children can, the exfoliative toxin, it's, you know what exfoliation is, right? You kind of get rid of your dead cells and then your skin looks nice and pretty. It causes layers of the skin to separate. And so children look like they've been scalded because their skin is peeling off. Enterotoxins, anything that's an enterotoxin is a GI toxin. May cause vomiting, may cause diarrhea, but it's a GI toxin. And toxic shock syndrome toxin. So it can overstimulate the immune system and cause that cytokine storm. It also produces a number of enzymes. Coagulase helps it form clots to hide from the immune system, so it can kind of wall itself off. Hyaluronidase and fibrinolysin help it to break down connective tissue, so it can invade into deeper tissues when it's ready. Lipases can cause host cell lysis. They digest the lipid layer. And nucleases can break down DNA. And that can be important because oftentimes bacteria like staph, they form a structure called a biofilm. And those infections are really hard to get rid of because it's this community that sort of protected itself. It's hard for the immune system to get in. It's hard for antibiotics to get in. And so when a patient has a biofilm that has formed, it can be very difficult to treat them. And that biofilm is a constant source of new bacteria going off to other parts of the body. They often build their biofilm using pieces of DNA as well as part of the scaffolding. So they want to digest DNA so they can use it as a scaffold. In terms of epidemiology, staph infections might be one of the most common bacterial infections that you will see. In general, in a clinical setting, you'll see staph infections mostly as a skin infection, so like boils and abscesses. But staph is associated with the nasopharynx. It can cause GI infections, and it can cause urinary tract infections. It's kind of it does everything. And it's also one of the most common causes of nosocomial infections. What does that term mean, nosocomial infection? Hospital acquired. So you were in the hospital for something else and you got an infection while you were there. It could be because maybe visitors brought it in. other patients brought it in, or your healthcare workers transferred it from patient to patient. But because staph is so ubiquitous on everybody, and it can form biofilms and live on surfaces, it is very well established in hospital settings. And what we'll see a little bit later in this set of slides, and with a lot of our different bacteria, when you have an infection that has established itself so well in a hospital, you tend to have an infection that is also very highly antibiotic resistant. So not only are these people, you go into the hospital because for some reason you are not well. You have another illness, that's why you're in the hospital. You've had surgery, that's why you're in the hospital. Even if, you know, the strongest athletes, if they have an injury, that makes them prone to infection. So if you're 49ers fans, any 49ers fans? Alex Smith was the quarterback for the 49ers, and he got nailed when he was quarterback at Washington, snapped his leg. He almost lost his leg to staph infection. I mean, he's a professional football player, and quarterbacks aren't like the guys, right? They're healthy. They can run. They can throw. They're in peak physical condition, and he almost lost his leg. It was a hospital-acquired infection. So staph infections, you can Google like staph infections in football. They go around locker rooms a lot, especially what we call MRSA, methicillin-resistant staph aureus, MRSA, whatever you want to call it. Increasingly common in both community and hospital settings. So in a locker room, at your gym. Okay. Everybody wipe down, right? You would think after COVID that everybody would be really good about wiping stuff down. They're not. Wipe stuff down. Okay. So about 33% of people worldwide are estimated to carry Staph aureus, and at about 2% carry methicillin-resistant Staph aureus, just as part of their normal flora. Oops, wrong way. And in the US, 90,000 infections per year, 20,000 deaths. It's a very, very important pathogen. Okay, so I told you about kids getting staph infections. So this is the bottom end of a child, most likely infant, who has what we call staphylococcal scalded skin syndrome. It looks like a burn. And it looks a little bit more on your computer. It probably looks a little bit better than it does on this screen. And so people were getting arrested for child abuse. They were being investigated by CPS because it looks like you dumped your kid in the bathtub and the water was too hot. But it's actually a staph infection that is causing the skin layers to separate. And so this skin here is peeling off, and you have the redness and raw skin underneath. So it looks like a burn. You can also have this type of, it's an impetigo, it's a bullous impetigo. These are basically like fluid-filled blisters because, again, the skin layers are separating. It's not quite the peeling we see with scalded skin, but it still has some skin layers separating and filling with fluid. And those are both caused by exfoliative toxin, which separates layers of the skin. And we can also have staphylococcal food poisoning. So throughout the term, as we talk about different organisms, I pull like some of the case studies from the text so we can talk about them. So 18 people at a retirement party became ill approximately 3 to 4 hours after eating. When you're talking about food-borne infection, if you have symptoms about 3 to 4 hours after eating, it is almost certainly what we call an intoxication versus an infection. You have consumed a toxin that made you sick. It takes too long for the bacteria to grow and replicate that, you know, at dinner time, if you're vomiting, it was probably something you ate at lunch. But, you know, if you went to the party on Friday, Saturday or Sunday, you have diarrhea, that's probably an infection. Okay, so something that appears that rapidly after consumption is almost always an intoxication, the ingestion of a toxin. Most common symptoms were nausea, vomiting, and diarrhea. So obviously it's a GI thing. Relatively few individuals had fever or headache. Remember, if you don't actually have the pathogen producing toxin in the bloodstream, you're probably not going to have a fever. So it's limited to the GI. The patients don't have any nervous system complications really, or a fever. It's an intoxication. And it only lasted about 24 hours. It's one of those 24-hour stomach bugs that somebody got. It was associated with eating ham at the party. Relatively, a sample of the cooked ham was positive for Staphylococcal enterotoxin type A. A food preparer had cooked the ham at home, transported it to her workplace, and sliced it while it was still hot. Then she refrigerated the ham in a large plastic container covered with foil. It was served cold the next day. Cooking the ham, so when she cooked the ham, that would have killed any staph. So it's likely the ham was contaminated after it was cooked. And so the issue is that the delay in refrigerating the ham allowed staph to grow. The fact that it was stored in a single container allowed it to grow and talk to each other. They could do that quorum sensing and produce the toxin. Type A toxin is the most common toxin associated with human disease. The rapid onset and short duration is typical. Care must be used to avoid contamination of salted meats, such as ham. And maybe you were thinking, well, they ate cold ham. Maybe they should have just heated it up and they would have been fine. Staph enterotoxin is heat stable. It will not be destroyed by heating. So once the toxin is there, they could nuke the ham and they're still going to puke. And so the reason staph is commonly associated with things like ham is because staph grows really well on our skin, which is salty, and it grows really well on things that are salty, like ham. Okay, so here we have a case talking about toxic shock syndrome. So toxic shock syndrome was first described in the late 1970s. You have a 15-year-old girl admitted to the hospital with a 2-day history of pharyngitis and vaginitis. So she had a sore throat and she had a vaginal infection associated with vomiting and watery diarrhea. She had a fever and low blood pressure when she was admitted. She had a diffuse red rash over her entire body. Laboratory results were consistent with, so she had kind of like an acidic blood. She had issues with her urine. And she had what's called disseminated intravascular coagulation with severe thrombocytopenia. Basically, she had tiny little blood clots all over her body. And because of that, because the platelets that clot blood are all forming tiny little blood clots all over the body, they can't stop bleeding anywhere else. And so you start to get like internal bleeding because you have these tiny little blood clots everywhere and platelets can't do what they actually need to do. Her x-ray showed infiltrates on both sides, suggesting what they call shock lung. She was admitted to the ICU. She was stabilized and improved gradually. On the 3rd day, fine desquamination started on her face, trunk, extremities, peeling of the palms and soles. By the 14th day, her skin was coming off. Her skin was separating. When I say her skin was coming off, I don't mean like all of her skin was coming off and there was like raw muscle underneath, but like the layers of tissue were separating. And she was losing some of the layers of her skin. All of the cultures were negative, except for from the throat and vagina. So blood cultures were negative, skin cultures were negative. All these places that she's experiencing symptoms were negative, except for the throat and the vagina, from which Staph aureus were isolated. So the idea is that this toxin, called toxic shock syndrome toxin, can be produced by the bacteria who are living in a particular place in the body, in the throat, in the genital tract, right? The bacteria are there only, but they're producing this toxin that is being pumped throughout the body that causes full body symptoms. But not in everybody. it is estimated that more than 90% of adults already have antibodies to toxic shock syndrome toxin. You have been exposed at some point in your life. But unfortunately, this can be fatal. So if you have the textbook, you've seen this picture, and you know it is a picture from an autopsy. So this is a patient who died of toxic shock syndrome. Again, like these areas that look where the skin has basically come off, and you see all that rash, all the redness because of the coagulation, there are no bacteria in there. It's only because of the toxin. Really commonly, though, what you might see in a clinical setting are cutaneous infections, skin infections. So you can have what is called impetigo. These almost look like more dry, kind of scabby types of infection. But you can also get folliculitis, so infection of the hair follicles. And they can cause kind of these deep boils or abscesses. And unfortunately for this guy, it's right on his butt. So he has a big staph infection on his butt. And they can also cause wound infections, because remember, it's on the skin. So if you have an open wound, your skin bacteria can jump in there and cause an infection. These types of abscesses, of course, if left untreated, the bacteria can continue to penetrate into the body, produce toxins, etc. And the treatment is actually relatively straightforward. You go to the doctor and you get the wound drained. So those of you who are working with patients, you may end up doing, you're like Dr. Pimple Popper on steroids. You are draining these abscesses. If they're really big, you pack them with gauze and antibiotics. Sometimes you leave them open to heal. It depends, right? You might have to debride and remove dead tissue. But, and again, that poor guy, and they can develop really fast. You might look at that and go, well, man, how did he not notice he had that big giant pimple on his butt? And let it get to that point. It might have been 24 to 48 hours. They can get big really quick. So the other thing that some staph can do, they can cause what we call bacteremia, the presence of the bacteria in the blood. So far, we've really only been talking about the presence of the toxins in the blood, but the bacteria themselves can get in the blood. And of course, that is a huge problem. You don't want bacteria in your bloodstream, because then they can get deposited to all the different areas of your body. And one of those areas that they can go is the heart. So you can have patients that develop endocarditis. Okay. And on Wednesday, we're going to do dental bacteria. A lot of times people don't realize how important your oral health is for your overall health. But people who have poor oral hygiene also tend to develop endocarditis and other bloodstream bacterial infections. And it's the same thing with your pets. So even though they're going to charge you $1,000 to scrape your dog's teeth, you probably need to do it. It's very important. Which is why I think, everybody should get to have dental insurance. But that's just me being, the government should provide stuff to us. Staph endocarditis, a 21-year-old woman with a history of IV drug use, HIV, and a relatively low CD4 positive T cell count. She doesn't have AIDS. The count is high enough that we wouldn't call this AIDS, but it's not great. So she developed endocarditis caused by Staph aureus. She had a 1-week history of fever, chest pain, blood issues. She had a heart murmur. And she had kind of infiltrates in her lungs, bilateral, so in both parts of the lungs, blood and sputum. So sputum is like mucus, that you cough up. So her blood and her sputum were positive for methicillin susceptible Staph aureus. So methicillin should get rid of it. She was treated with oxacillin, which is a penicillin derivative, for 6 weeks. That's a long time to take an antibiotic, which resolved the heart infection and the pulmonary abscesses. So this illustrates the acute onset of staph endocarditis factors, risk factors of IV drug use, and the frequency of complications caused by septic emboli. So basically, chunks of infection that travel through the body. So Staph aureus can also cause pneumonia. It's not terribly common, but it can. Okay. You can also get osteomyelitis, so kind of like bone infections, and septic arthritis. This is generally going to be, especially if you've had surgery. So I knew somebody who got like a hip replacement, and they got a staph infection like in the hip replacement, in the bone around the joint replacement. Septic arthritis is like in your like in your knee or whatever. So normally arthritis is like an inflammation, and it's painful to move your joints. Sometimes it's impossible depending on the type of arthritis. Septic just means it's caused by a microorganism. So there's staph growing in the joint fluid and causing that. So, you know, what you can think about as you think about all of these types of infections is how the bacteria spread from the skin to the internal areas of the body. My watch just told me I should go to class. I'm already in class. Less common types of infection with staph are coagulase-negative staph. This is basically saying any staph infection that's not Staph aureus. So most commonly in the clinical setting, you will see patients that have a Staph aureus infection, but every once in a while they might have something else. The other species of staph tend to cause endocarditis, catheter and shunt infections, prosthetic joint infections, and urinary tract infections. You have to be pretty compromised. Like somehow they had to get into your bloodstream. You had to have a device implanted into your body. Okay. So here they talk about a coagulase-negative species of staph that causes endocarditis. The woman was an active cocaine user who presented with weakness in the right extremities, chills, tired, shortness of breath over the preceding 10 weeks. On admission to the hospital, her heart rate was off, her blood pressure was low. She had a low-grade fever, a heart murmur. Her CT scan of her brain showed an issue on the left side, like a clot type issue. 4 sets of blood culture were positive for this species of staph. It was penicillin resistant, but susceptible to all other tested antibiotics. Didn't matter that it was penicillin resistant because the patient actually was allergic to penicillin. So you had to pick a different antibiotic. They picked vancomycin and gentamicin. The fever went away after 3 days, and subsequent blood cultures were negative. Gentamicin was discontinued after 1 week, and vancomycin was continued for a total of 6 weeks. Over the next 7 months, she developed an issue with one of her heart valves, so they had to replace it. So endocarditis, right, affects the heart valves. This particular species is more virulent than other coagulase-negative staph, and it's more likely that you'll see it causing infection in what they call native heart valves. So it can cause an infection even if you haven't had like a heart valve replacement before. It can just get in there and cause an infection in a standard healthy, right, she's a cocaine user, I don't know how healthy she is, like healthy heart. With the secondary complications, you can have brain issues caused by those pockets of infection that can travel through the body. Persistent bacteremia is characteristic of intravascular infections such as endocarditis. So one of the challenges would be with endocarditis, if it establishes that infection in the heart, on the heart valves, if it forms a biofilm in there, it will continue to kick off bacteria that will travel through the body. So that's what they mean, you have that persistent bacteremia, because those bacteria will constantly be traveling through the body. Staph infections are commonly diagnosed by microscopy or nucleic acid tests. You can also do culture. You've done this before and you'll continue to do it. You'll do it one more time in this class. MSA plates, mannitol salt agar. Staph aureus will turn yellow because it ferments the mannitol, which changes the pH of the media, causing it to look yellow. Most of them are beta hemolytic. It doesn't look great on this image. projected on the screen. But remember, beta hemolysis is a complete breakdown of all the red blood cells. So you'll see your colony of bacteria and then a clearing, a complete zone of clearing around it. That's beta hemolysis. And then here's the MSA plate. So an uninoculated area. This is Staphylococcus epidermidis. It grows on the plate, but it doesn't ferment mannitol like Staph aureus does. So you get that yellow color because of the fermentation of the mannitol. You can also do tests for some of the surface proteins. So I'm not going to ask you to remember msgrams, but you can look for the surface proteins that staph produces. And also you can look for a patient to have antibodies against staph. That is probably not terribly informative because most people have staph already on them. However, so the presence may not be informative. The levels might be. So if a patient has really high levels of anti-staph antibodies, that could be indicative of an ongoing infection. For the most part, most physicians assume if you come in with a big boil or an abscess, you have a staph infection. And they will proceed with treating it as if you have a staph infection. So how will they treat it? Not usually with penicillin. Most strains of Staphylococcus are resistant to penicillin. Vancomycin and methicillin resistance are increasing significantly. So they'll have to go to other antibiotics. So what often could happen is if a physician suspects you have a staph infection, they might prescribe you, they probably will prescribe you vancomycin. And they will also take a sample to run for antibiotic susceptibility testing to see if vancomycin is good or if we have to transition to something else. If there's an abscess, if you can physically remove as much of the infection as possible, that's really helpful. That can help the immune system get in and help clean up the rest. It can make antibiotics get there. If you're picturing this big pocket of infection, antibiotics are going to have a hard time penetrating that. Immune cells will have a hard time penetrating that. So if you can remove as much of the infection as possible, that can allow antibiotics and immune cells to get in. Proper wound healing and disinfection prevents most infections. Spread is difficult to control because most people carry it. It's kind of inevitable. And so what we see, methicillin-resistant Staph aureus. So my death numbers were updated since this was last published, that 20,000 deaths. This was the CDC report from 2019, but you can see their most recent data is from 2017. So every few years, the CDC gets it together and publishes an antibiotic resistance profile of what's going on in the US. They were relatively busy starting in 2020, so I don't expect one of these to come out anytime super soon. But in 2017, 10,000 deaths, a couple $2 billion in excess healthcare costs, very difficult to get rid of just because it's so well established. Questions about staph? It's coming to get you. You already have it. Yeah, and we'll do that. I don't think so. Next week is teeth, then it's staph. So not in this coming week, but the week after, we'll look at staph. So we'll see how far we get with strep before we go home for the long weekend. So Streptococcus and Enterococcus are in this section. They are together because Enterococcus used to be considered strep. It was one variety of strep, but now it's its own genus. So they are classified by serology, and a scientist, her last name is Lansfield, came up with the groupings. And so they're grouped A through W. So you'll have group A strep, group B strep, group D strep. They can also be classified by how they break down blood. Some of them are beta hemolytic. They break down all the blood. Some of them are alpha hemolytic. They can break down some of it. And of course, their biochemical properties. The one that many of you have probably experienced as an infection is group A strep, Streptococcus pyogenes. So they'll call it group A strep, strep pyogenes. You can see that under the microscope, they are gram-positive coccus-shaped organisms, but sometimes if you do your preparation really well, like if you make your slide really well, you can preserve the chain that they grow in. That's why it's Streptococcus. It's a chain of cocci. They are beta hemolytic, so you can see the complete digestion of the red blood cells on the plate. So if you ever had strep throat, this is the infection you've had. They have a number of virulence factors that help with immune evasion, including a capsule, but they also have other proteins that we call M and F proteins that help to block complement and impair phagocytosis. So they can hide from the immune system pretty well. Oops, I went backwards. I went backwards again. There we go. They also produce toxins. So they have streptococcal pyogenic exotoxins. They can cause fever. Streptolysins cause the lysis of host cells. Streptokinases also can cause lysis of host cells, and they have enzymes that break down DNA. So they're nasty, especially group A strep is pretty nasty. So the common clinical disease, though, is pharyngitis, strep throat. And you will see the pockets of infection commonly on the tonsils. So this is a really kind of straightforward one to diagnose. Patient comes in, they have a sore throat. They got infection all over the back of their throat. But there is a rapid strep test that's available. So within 20 minutes or so in an urgent care, you can find out if you've got strep. Now, untreated strep, even though it seems like, oh, it's a super common infection, like I have a friend who has it literally right now, super common, it can be dangerous. So we have antibiotics. So we don't tend to develop severe complications from strep throat because you'll be prescribed antibiotics. If left untreated, these bacteria do produce exotoxins. And so for people who were born prior to antibiotics, that childhood infection with strep throat would cause something called scarlet fever. And you can see here you have the redness, right? The fever that develops throughout the body. That toxin causes damage to the heart, and those symptoms can show up like decades later. That's actually how, like I would say my grandma died of scarlet fever. My grandma died because her heart was bad because it was damaged from scarlet fever when she was a kid. Because my grandma was born in the 1920s and there weren't antibiotics. So it got her, 70 years later. So these untreated childhood infections can be a major complication. So if you have a patient who shows up with strep throat, make sure that they do seek treatment. We can also see skin and soft tissue infections with group A strep. It's a more common cause of like cellulitis, so that like redness and peeling, and I'm sorry, this one's going to be gross, necrotizing fasciitis. So Streptococcus pyogenes, group A strep, is one of the bacteria that causes necrotizing fasciitis. So necrotizing fasciitis is not an organism, it's a disease state. It's a deep infection where you have cell death of like the muscles, the fascia, the deep tissues die. And so, again, strep, group A strep, is one of the bacteria that can cause that deep skin and soft tissue infection. And so, again, I know it's a gross picture. This is the same appendage. This is what it looks like on the outside. And then on the inside, all of that tissue is dead. It's necrotic. These are very dangerous because that can travel throughout the body relatively quickly. And that's when you read about, oh, this patient like went swimming and got some weird infection and now they lost their arms and legs. Because sometimes the only way to stop the infection, if it's progressed, is removal of the limb. So, and that's not always a guarantee either, because it can spread very quickly once it gets into those deep tissues. Strep can also cause toxic shock syndrome. So this was a 46-year-old man scratched on the arm by his dog, and then he accidentally reopened the wound at work the next day. Then the day after that, so 2 days after the scratch, he developed a fever, chills, backache, and muscle pain. Remember, this was on his arm. So why is his back hurt? When he presented to the ER, he had redness at the site of the scratch and a serous discharge. So it wasn't bleeding, but it was like the secretion of plasma. So kind of that, I don't know if you've ever secreted plasma. I don't know. It's kind of a off-white color, beigey color liquid. Cultures of the wound and blood were collected. IV antibiotics were started. Obviously, fever, chills, backache, muscle pain. This is going systemic. So they did IV antibiotics. Within 10 hours, he became confused and had low blood pressure. He was transferred to the ICU. The redness over the wound had spread, and he got all of those like fluid-filled blisters around it. Taken to surgery, during which yellow fluid in the muscle tissue was drained. Cultures from the surgical site, the original wound cultures grew strep pyogenes, group A strep. After surgical debridement, removal of the dead tissue, the patient continued to decline with abnormal liver function, renal failure, so the kidneys went out, pulmonary distress, and cardiac abnormalities. He developed persistent low blood pressure and died 3 days after admission to the hospital. So the fulminant, that means like really rapid progression of the disease, and multi-organ failure underlies the need for aggressive medical intervention. The dude got scratched by his dog and died. Is that going to happen every time you get scratched by a dog? Of course not.
So is the dog was infected or something?
It could have been that the dog had it on his nails, or that he had it on his skin already, and when the dog scratched him, it got in. Yeah. Okay. And so I think with that happy note, we'll see that these are some of the other issues that you can have with group A strep infections. So bacteremia, that rheumatic fever that involves the heart and lungs, and kidney issues if it produces those toxins. So that's where we'll stop for today. Still love on your dog, it's okay. Cats are evil, don't love on them. But your dogs, they're fine. Don't let them bite you though. And don't let them lick your open wounds.